All right, thank you for the introduction, Dr. Chow. So for those of you who don't know me, my name is Ryan Quinn, and I'm one of the Echocardiography fellows here at St. Mike's. Today, I am pinch hitting. We had our the speaker that we were going to have drop out a couple of days ago, so I'm pinch hitting a little last minute, but I think this will go well. The objectives today is we're just going to go over some interesting cases and pathology. The format is a little different from how I had this set up originally, but essentially there'll be 7 cases. How I originally made this is that when we go through each case, I was going to pick on one person to go through each of the images themselves and come up with an impression and diagnosis. But in talking to Dr. Chow yesterday, we thought it'd be more interactive. If instead of doing that, I went through the cases myself, and then I'll ask questions throughout the cases at the end about the diagnosis or what certain signs are. So that's what we'll do. And then after each case, there'll be about 1 to 2 slides of didactic teaching on that topic. This is also my very first time doing these interactive questions. Myself and Dr. Chow put it together yesterday, so I really hope it works well. But if it doesn't, then we'll just have to improvise. So I will ask everyone, I'll give everyone maybe just a minute now. Here is the QR code. You could just use your phone. It's pretty simple. We tested this out yesterday. If you just scan the QR code, it'll send you to a website. Really, the only rule of engagement is just skip the registration. It's going to tell you to register, but you do not need to do that. So just skip that registration right now. And again, just try to answer all the questions. This is completely anonymized. I'm not sending any results to Dr. Chow. I don't even know who is answering what questions. It's just to keep people engaged and see what people think the answers are. So like I said, I will give everyone 30 seconds to get this set up, and then I have a practice question to see how well it's working on the next slide. Okay, I'll give it just a couple more seconds, and then we'll go to our practice question. Okay, let's see how well this works. So since it's in honor of Sonographer Week, here's the question. I think once you guys register, it already popped you. Okay, so it's working, or at least it's working for enough people. Perfect, look at that. Everyone loves the sonographers. Okay, great. So I'm glad that works. So then these will just pop up sporadically as we go through. It'll load up on my screen anyway and on your phones. So yeah, just keep answering questions as we go. If the QR code did not work, and for anyone who joins in late, I will repeat this again. You could always just text this number 37607 and then my name, which is kind of long. And then once you've texted it once, you're automatically in the group. So great, perfect. Poll everywhere. So far, so good.
Just wait until they have to do my name as a poll everywhere, Ryan.
Yeah, oh no, except now it's not letting me go forward. Oh no, poll everywhere. I was too excited. Okay, let me see why. I might have to exit out of the presentation. Okay, so that seems to be the only glitch, is when it's in presenter mode, it doesn't let you go forward when people are answering. Okay, so case number 1. Again, like historically, I would ask one of the residents to do it, but to not pick on anyone, I will just do it myself. I'm going to try to do this in a way where I describe as much as possible without making the answer maybe blatantly obvious, which is a bit of an art, and I may or may not succeed, but I'll give it my best shot. So the first case is a 20-year-old male, and all we know is that he was found down and that they ordered an echo for this gentleman. And I'll proceed to go through the slides. Again, some of these videos are already a little choppy on my end, so I can only imagine how choppy they are on your tiny iPhone screen, but we'll give it our best shot. And also the other thing I'll say is that there's not necessarily pathology on all the images. So I might skip through a couple of them. When I was making people work through them, I wanted the whole picture, not just pathology on every slide. So that's why some of them may be less informative than the rest. But as you can see here, parietal long and looks pretty normal so far. Good LV function, good RV function. Mitral valve seems to be working well. And then this is where things get a little interesting. So he clearly has a jet of mitral regurgitation that is, I don't know why the videos are stopping. That seems to be coming right from the middle of the leaflet. And as you can see, color compare going on right there. I think there's no doubt this is directly in the middle of the leaflet, which is obviously not classically where we see mitral regurgitation. What I pointed out here, and what I think is interesting, is that we rarely get a CW from the parietal long axis because it's so rarely parallel to the regurgitant flow. However, in this instance, we're clearly capable of getting that. So that's the unique aspect of this slide. Normal dimensions on this gentleman, maybe a little bit of eccentric hypertrophy. Aortic valve seems to be working well here. Pulmonic valve also working well. Another shot of the aortic valve. And then we're back to the mitral, where again, you could see this regurgitant jet coming down, again, very parallel to flow in the short axis. So you get these great CW Doppler jets just because the parallel nature of the flow. Now we're doing the short axis, obviously going to the apex. Looks like there's good ventricular function. There may be a hint of something hyperechoic here in the inferior lateral wall of the apex, but still function seems to be preserved. Overall, seems to have good biventricular function. Maybe the LV is a little dilated. It looked like it was some eccentric hypertrophy before. The RV appears to be working well. Two chamber looks good to me. And again, we'll go back to this very peculiar MR jet. Now, the reason I threw this slide in is because, again, when we had those short axis apical shots, it did seem like there was something kind of hyperechoic. And here again, you get that sense that there is an hyperechoic structure in the apex of the inferior wall. There may be some comet tail artifacts here, but it's a little hard to tell. But here you get the sense that there is a little bit of a comet tail artifact down over here. And again, you still have this hyperechoic structure. So my question, this is for, again, if anyone joins a little late, I'll put the QR code. We couldn't put it for some reason on the slides with the questions, which is a little annoying, but if you did join in a couple minutes late, you could please scan this QR code. So question number 2, what is the mechanism of the MR in this person's case? So seems like, oh, I'll wait for the answers. So perforation is the leader, but some people, fifth of people saying congenital malformation. All right, so yeah, so it's about 80% on perforation, 20% congenital malformation. No one said ischemic and no one said functional. Well, now a couple more coming in with congenital. Yeah, once again, it doesn't let me go to the next slide once I'm on one of these poll everywhere. So let's see if I, There's a way to do this.
Try locking the pole.
Try locking it, you think? Yeah. Let's see. Then let's see. Nah, still.
Yeah.
Yes. Yeah. It was going so well, pull everywhere until this happened. That's okay. I could just do it the old-fashioned way. So then we'll go to question 2. So I'll explain a little more. It was felt to be a perforation, but I actually don't think congenital malformation is the wrong answer. But what is the cause in this person's case? So is it infective endocarditis? Do you think it's a connective tissue disorder? Did you get, as I say, Bon Jovi shot through the heart? Or is there just not enough information to say? So most people, again, saying not enough information, and then a couple people just sprinkling in the other things. Now a couple more going with Bon Jovi. I should also mention, this is a case from Hamilton. I don't know if this affects anyone's decision making here. As soon as I said that, more people went to Bon Jovi. I like that. Okay, let's see. So yeah, most people say not enough information. Number 2 is that he got shot, and then a connective tissue disorder or infective endocarditis. So since I've now realized that I have to exit the screen to move on, I will just do that. I've tried. Yeah, it doesn't work. So the answer is, here's the sweep from the apex. This guy actually did get shot through the heart by his buddy. And as you can see here, I hope it's playing well, but I'll try to, it kind of looks like a bullet, this little thing. I think that works pretty well on your screen. So the story for this guy is, oh, here's the impression of the echocardiogram. So essentially everything was normal. He had this moderate MR that was felt to be secondary to a perforation of the anterior mitral valve leaflet. And then there's that echo density in the apical inferior wall with a mild perturbance in the LV cavity. And that was, he was shot with a pellet gun. I'll go into the story in a second, but the reason I wanted to bring this in is because trauma echoes are something that we see, and both for the sonographers who have to do the trauma echoes and for the MDs or whoever's interpreting, they are something that we have to do and assess. It doesn't happen very commonly, but it's still good to know the protocol and the things that you're looking for. So specifically with trauma, you need to know whether it's blunt or penetrating trauma. In this case, this guy was clearly penetrating. And then you're going through the gamut of all the things that could be injured, essentially. I think the most common, or not the most common, but the most deadly thing that you need to rule out here is, of course, effusion and tamponade. And then after that, you're going through just all the kind of structures. You need to see if there's valvular injury, like in this guy's case, or there's any ventricular injury. Your coronary arteries can be cut or sliced, or they can suffer trauma. You can have any aortic trauma. And of course, you need to make sure that there's no signs of hemorrhage or volume depletion, as if they have a very hyperdynamic ventricle. In this guy's case, so the risks associated, because he had that pellet lodged in him, they felt that there might be a risk that his ventricle is ruptured, that the pellet could embolize, or whether you have an infection. So what happened with him is he was playing with a pellet gun, apparently in front with his friend, and somehow he accidentally shot himself in the chest, or his buddy shot him. And then he went to the hospital. He went to one of the non-cardiac hospitals in Hamilton, and they did a CT, and they found that that pellet was lodged into the myocardium. That echo was ordered, the one that I showed you. And then at that point, he was seen urgently by cardiac surgery and cardio. And the initial plan was actually to go for surgery. I remember this case because I went through like multiple cardiac surgery and cardiology case rounds. And eventually, after a lot of discussion, the decision was to treat him conservatively with watchful waiting. And eventually, he ended up leaving AMA, as most 20-year-olds would. This is his echocardiogram from a year later. This was April 2021. That shows the bullet, that pellet that's still lodged right in his heart. So this guy just lives with a bullet in his heart, which is kind of I guess it's a kind of cool bar story for him. What I do want to note, though, is what Dr. Chow brought up yesterday, I think it's a good point. So the feeling from all of the case discussions was that the perforation, the mitral valve, was due to this pellet. There is still a suspicion that this could have been a congenital abnormality, just based on how, I want to say, neat that perforation was in the mitral valve. When they were at McMaster, I tried to find a good sweep. They did feel that based on the sweep in the CT, that the trajectory of the pellet did go through the mitral valve. But a point that was brought up is that if a pellet actually did go through the mitral valve, you'd have much more profound mitral regurgitation. So I don't think it's necessarily wrong to have thought that this may have been a congenital abnormality and just an incidental finding. But I guess we will never know. So that is case number 1. If you guys have any questions or comments, obviously, please feel free to unmute yourself and make whatever comments you have. We'll move on to case number 2. So this case, again, without saying too much, a 39-year-old gentleman who was sent for an echo due to shortness of breath. His only past medical history includes asthma. And I remember this guy, he had been worked up for like years for shortness of breath, asthma, and he could just never get that shortness of breath under control. So he finally had an echocardiogram for it. And again, I'll work through that myself and then I'll ask some questions later. And if there's any that are not, I might skip through some of these images if they're not very informative or interesting. So clearly you can see here, the LV looks a little dilated. I would say first glance, the LV function is probably mildly down, 45 to 50 range, but otherwise, I don't really see any other abnormalities here. The valve function looks good. The RV function looks good. Maybe the LA is a little big too. Normal wall thickness here. A little dilated though, as you can see, 6.2 centimeters. And no hemodynamically significant regurgitation. Tricuspid valve, video is not working, so I'll skip it. And here's the pulmonic valve. So this is obviously where things get slightly interesting, because clearly you can see there's a very hyperechoic, what looks to be slightly independently mobile mass or structure attached to the pulmonic valve. And you can see there's a little flow convergence or flow acceleration at the level of the pulmonic valve as well, which is not surprising based on what we see. Here is just another view of that hyperechoic structure. And you can see it does look more independently mobile here. It's quite large. Short axis. Again, LV function looks a little down here. So here you can see in the apical 4 chamber, there seems to be pretty good LV function. Again, maybe a little bit down, but I don't see any egregious wall motion abnormalities, like no akinetic or dyskinetic segments. Yet there again appears to be a layered hyperechoic structure right at the apex. I want to just point out what the function of the apex. It looks to be okay too. Maybe there's something as well in the RV apex, it's hard to say. We could skip, this is just to go through again, when I had the residents doing this themselves, diastolic dysfunction was one of the things I had them work through, but in this case, we could skip through that. So again, another view of that hyperechoic structure mass, the LV apex, no color flow through it. Short axis, more of the same. As you can tell, it's a pretty big mass that's there. Here's a view of the RV outflow tract. And what I want to point your attention to is what's going on over here. Again, something hyperechoic, seems to be independently mobile. And maybe something here as well. And then the reason I put this picture in was it seems here, it's a little more convincing that there also seems to be obliteration of the RV apex. So my next question for you, there's a lot of clots here. I gave the answer away, but that's okay. I think everyone suspected they were clots. Where were they all located? See who was paying attention to this case. Okay, so it seems like most people are saying the pulmonic valve, both apices and the RV outflow tract, and that's correct. So then I'll move on to the next question. I wonder, no, there's no good way to do this. So first of all, I'll give the impression of the case. So they said it was a mildly impaired LV, 45 to 50%. The RV was also mild to moderately dilated with normal function. There's obliteration of both apices by a layered echo density. Abnormal echo density attached to the pulmonic valve without stenosis or regurg. And there's also a mass attached to the endocardial border of the RVOT. So what is the unifying diagnosis here? So we got essentially clots everywhere. Clots in both apices and clots in clots on the valves and the RVOT. So did this guy just have really bad myocardial infarctions before? This should say Carney's complex, not syndrome. Is this amyloidosis, or is this Loffler's endocarditis?
Seems to be a very well-informed group.
yeah, I'm very impressed. Somebody said Cardi's and backed out was there in that comment. But yeah, you guys are right. This is Loeffler's endocarditis, which is not something we see very often as well. So congratulations on everyone getting this one right. So it takes a second to take this out of presenter mode to go on. But it's exactly as you said. So this is directly from the report. It's consistent with the diagnosis of endomyocardial fibrosis or hypereosinophilia, which is also known as Loeffler's endocarditis. And the reason for that is that there's thrombi essentially everywhere. They're in the cardiac chambers and on the valves. And furthermore, when we were looking at both the LV, or really with the LV apex, the function was great. So it wasn't like this guy had some sort of myocardial infarction and hemostasis to call these clots. It was really from the eosinophilic accumulation. So in this case, this young gentleman, again, this asthma and all that was just part of this hypereosinophilic syndrome. He was finally diagnosed with EGPA, formerly known as Church-Strauss syndrome. He had an MRI that confirmed the endomyocardial fibrosis in his heart. He was started on prednisone. Apparently, he did phenomenally. His symptoms entirely cleared up. His EOS cleared up, and actually, his repeat echocardiogram showed that all those thrombi had cleared up entirely, and his LVF had gone back to normal. So this guy did really well, and this is not a diagnosis that we see very commonly, but it's hypereosinophilic syndrome, also known as Loeffler's endocarditis. And essentially, what it is an overproduction of the eosinophils that leads to cardiomyocyte infiltration and injury. There's really 3 stages, and typically when we see them, it's usually stage 2 or 3. Stage 2 is when you start getting the endomyocardial thrombi. And when I was told, or when I was reading about this, what I heard is that you get the eosinophilic infiltration of the myocytes, and that leads to then platelet activation aggregation. So that's actually why you get these thrombus or thrombi everywhere. And if it's left untreated, it kind of goes to the third, the fibrotic stage, where you get, a restrictive cardiomyopathy. You typically get heart failure, and you could also have some primary valvular issues. So I think the clue here again was that this person had thrombi everywhere, and the LV function looked pretty good. So that should make you think that this isn't just, a typical MI, and there's something systemic going on. But yeah, good job, everyone. So case number 3, 55-year-old lady who's in for just an annual surveillance echo. I see someone made a comment. Oh, thank you, Dr. Chow. So again, I'll just go through some of these quickly. Long axis, not too many abnormalities here. Looks like the LV function's good. The LA looks a little large. The valves look okay to me. Skip that. There's some, mild, at least mild MR, probably mild MR. Maybe some trace AI as well. Looking at the aortic valve, appears to be functioning normally. Trace AI maybe at worst. And now we got to look at the ascending aorta. There does seem to be, something happening in this area here, where it seems like there's two kind of tubular lines. And there also sees, they use variance at McMaster, so that's why everything looks green, but it does seem like there's some flow acceleration right through this area. So here's the aortic valve. You can see it opening. And then LV looks large here. The LA looks large. LV function looks generally preserved, maybe slightly down. Some MR, posteriorly directed. TR as well. And I know that last slide doesn't work, so I'll skip it. So here we have the abdominal aorta. And clearly you could see, well, I shouldn't say clearly, but it looks as if there is color flow through this part of it. And maybe there's something going on here as well. Here's a color compare, again, of the abdominal aorta. Does seem like something's kind of flapping in the wind. Pulse wave through that area shows systolic flow. Here's the suprasternal notch. There's, again, maybe some flow convergence here. And here is a CW down the ascending aorta. And there's a pretty high gradient, 48, down the ascending aorta. So the question here is, what pathology or pathologies does this patient have? Does she have a chronic type B? Does she have a chronic type B with a previous type A? Does she have chronic type B with a previous type A and aortic stenosis? Or does she have exactly that, but bicuspid aortic valve without stenosis? Okay, so it seems like bicuspid aortic valve currently is leading. Okay, things are changing. Okay, so it seems like most people think it's a chronic type B with previous type A and a bicuspid aortic, which obviously does go hand in hand with aortopathies. Second, so it's chronic type B with the previous type A. So I will get out of this. See if I lock this in my, it's quicker. So for her, what she had, or here's the impression. So she had a mildly dilated LV with moderate eccentric hypertrophy. The LVF was normal. There's no regional wall motion MRIs. Her RV was mildly enlarged with impaired function. And the important things to note here is that she had ascending aortic graft with increased velocity at the repair site, and the linear echo density abdominal aorta differential flow consistent with the dissection flap. So she had a chronic type B. I think everyone saw that, with flow through the true lumen. And then when I was showing you the ascending aorta, that was the graph there. And she actually had a perfectly normal aortic valve. It was opening well. It was tri-leaflet. But she did have very, very high gradients because they felt that there was an area of narrowing at the anastomosis site of the graft. That's why we could see the flow convergence. And that's why you got the very high CW gradients when at the suprasternal angle. So the correct answer was chronic type B with a previous type A. And you know that there's a previous type A because of that ascending aortic graft. So this is her story. Acute type A dissection at a young age, then had a chronic type B, and she had annual follow-up echoes. So for chronic type Bs, you do need serial imaging actually with CTs or MRIs is what the guidelines recommend. So I know these are echo rounds, but it's still something that we see. So how often should you do serial CTs or MRIs in people with chronic type B dissections? 6 months, 12 months, 3 to 5 years, or only if there's signs or symptoms of peripheral or organ ischemia? All right, so it seems like most people are saying every year, with some people saying 3 to 5, and some people saying only if there's signs or symptoms. So I'll lock this, and then I will hop out of here. So just a couple things on acute aortic dissections and echocardiograms. And I'll go through the answer to the last question in a second. But the TT sensitivity is okay, not great though. And there's a wide range here. But really, TEs, if you're going to diagnose it with an echo, which you don't typically need to, but if you're going to make the diagnosis with an echo, you'll need a TE. Of course, you can make it with a TT. The problem here is that you miss a lot of the, you don't visualize the entire aorta. That's why imaging with CT is typically the recommended imaging modality. For you cardiology trainees, as someone who just wrote my exam, I could tell you that this is a question that comes up on the Royal College multiple times, is how to differentiate a true lumen from a false lumen. So I won't go into this in detail right now, but this is something to note and then look up when you have time. So for management of, because I feel like as, at least for cardiology trainees or cardiologists, we deal with acute dissections, but we don't often deal with chronic dissections. At least I didn't, because usually that's vascular surgery deals with that. Just to go over the Stanford classification, which is typically how we classify these, we group them into type A or type B. And it really just is where the takeoff is, where the origin of the dissection is. If it's distal to the innominate artery, then it's a type B dissection. If it's proximal to that, it's a type A dissection. Type A's obviously have a much, much higher mortality risk. In terms of type Bs, we classify them again as complicated, high risk, or uncomplicated. Complicated means they either have a rupture, malperfusion, like these are blatantly obvious and these are going for surgery right away. High risk is anyone who has recurrent pain, refractory hypertension, or any radiographic high risk features, which typically only the radiologist need to know, but they would comment on. And uncomplicated is if it has none of the above. And what I found is actually very simple. It's the same as acute, except you don't treat it surgically. You treat them with what they call anti-impulse, but it's just beta blockers and antihypertensives to a heart rate of less than 60 and a systolic of less than 120. And you get them, of course, to exercise restrict, because that's going to make their blood pressure and heart rate go up. And really, you just watch. So initially, you do a CT or MRI at the 1, 6, and 12-month intervals to make sure that it's not progressing or not changing or growing rapidly. And then you just do it annually after that. So that was the answer to the question. You get them done annually. And about 20 to 50% go on to require intervention. All right, case number 4, a 40-year-old female with shortness of breath. So here, parietal long, the RV looks big. The LV function, there's clearly a wall motion abnormality here in the basal inferior septal region. It seems to be thin, akinetic. But what's interesting is the rest of the segments appear to be working well in this lady. Her mitral valve may be a little bit thickened, but otherwise her aortic valve looks okay. So when I was doing this with the residents and making them go through this, at this point, I'd actually asked them what the diagnosis was, because this picture is kind of pathognomonic for what pathology this person ended up having. So if you could, I mean, take a look at it, and if you could figure out what it is, kudos to you. But again, like I said, this is slightly pathognomonic, or it is pathognomonic of what pathology this person had. So take note of this image. Here's the short axis. Oh, and it's, for whatever reason, not running. But what I wanted to show you here, I don't know why the video is not running this time, is the basal inferior septum is thinned and akinetic. This video doesn't seem to want to work either. Oh, maybe I'll go back. Okay. For some reason, some of the videos aren't working, but some of them are. 4-chamber view here. Again, the LV looks a little dilated, and you could see the basal inferior septum here looks dyskinetic, rather. It's bulging outward in systole. RV seems to be okay. The LV walls may be a little bit thickened, maybe not. It looks potentially slightly thickened. It's hard to say. Oh, none of these. Oh, they are fine. It just takes some patience. Apical 2-chamber. And again, you see this kind of this bulged out akinetic basal inferior wall segment. Again, this is when I was with the residents. We were going through the diastology. As you can see here, the E primes in this person are exceptionally low, and his E is not that low. So it gets very high E over E prime levels to make you think that they have quite elevated left atrial pressures. This is a shot of the hepatic vein Doppler, normal. So for this person, they had an LV that was mildly dilated with a severely impaired LVF, 30 to 35%, an akinetic and thin basal anterior septal wall, an aneurysmal basal inferior wall, and a thin and dyskinetic basal inferior septal wall. The RV was mildly enlarged with mildly or moderately impaired function, and they said pseudonormal diastology. So the question is, what is the diagnosis? So is it amyloid? Is it hemochromatosis, Fabry's disease, carcinoid heart disease, or sarcoidosis? So it seems most people going sarcoidosis, a couple with carcinoid, and a couple with Fabry's disease. And again, you guys are very astute. Most of you would be right. This is sarcoidosis. And so just a quick slide on sarcoidosis. The pathologies that you find non-caseating granulomas when you do a biopsy. The classic findings is this basilar septal wall akinesis and thinning. So this is very like classic, typical pictures of this. You could see it in A up here. The anterior septum is thinned and akinetic. You also will get inferior wall, dyskinesia or akinetic or thinning as well. And that's what this strain is showing. The wall motion abnormalities are typically in a non-coronary distribution, and you'll typically get systolic and diastolic dysfunction. You can also see wall thickening in the other segments that aren't the inferior septum or inferior wall. And you can also get chamber dilatation and pulmonary hypertension. Typically diagnosed with FDG PET, but it can also be diagnosed with a cardiac MRI that show classic LGE in the mid-wall or subepicardium that again doesn't follow any sort of coronary distribution. But the point here, the teaching point is that these wall motion abnormalities are very pathognomonic of the basal inferior segments, the basal anterior septal or basal inferior septal, and usually it's thinned and akinetic or dyskinetic. So moving on to the next case, 82-year-old gentleman, decreased exercise tolerance, not exactly surprising in a gentleman who's 82, but I remember this guy, he said that in the last 6 months, he's just taken a huge drop off. So I'll try to, again, work through most of these slides quickly, but maybe as a bit of a pericardial effusion, but both LV and RV function seem to be preserved. RV may be slightly enlarged here. LA may be slightly big. Mitral valve looks okay. He has some concentric remodeling. Tricuspid valve, or sorry, pulmonic valve is looking good too. And then we do the PW through the pulmonic valve. And you interestingly get this pattern on every single beat that you don't typically see on the pulmonic valve. So my question comes up now, the first question for this case is, what is this sign called and what does it mean? So is it mid-systolic notching, indicating elevated pulmonary pressures? Is this your B bump, which means an elevated LVDP? Is this your L wave or BAT sign, which is an elevated LAP? Or is this McConnell sign, which is indicative of PE? Okay, pretty evenly split. Half the people are saying it's mid-systolic notching for high pulmonary pressures. Half the people are saying a B bump for elevated LVEDP. And I will get to the answer, but I'll just keep moving on with the case right now. Here's a look at his aortic valve. Looks a little sclerosed, maybe stenosed. We don't know what the gradients are yet. Tricuspid valve, some degree of TR. Here's the short axis. You see systolic flattening in both systole and diastole to indicate a volume and pressure overload. And there's also a pericardial effusion here to note. LV function looks good, but both atrium look enlarged, and the RV on first glance looks enlarged too. And you can see there's very abnormal motion of the septum as well, which goes along with what we saw on the short axis. Pericardial effusion is still present. To the gradients through the aortic valve, which weren't elevated. There's at least, mild, maybe mild to moderate TR. RV is enlarged. And nothing to note here, but there's no intraatrial shunt. And here is just to show that the IVC is plethoric. So in this person, he had LV was normal in size and function. He did have an akinetic apex. I skipped over that one slide because it wasn't loading, but there's no thrombus. RV is mild to moderately enlarged with mild impairment in function. There's evidence of both volume and pressure overload, severe biatrial enlargement, and moderate TR. So when I was asking the residents, I got them to go through the differential for RV volume and pressure overload, but we could just talk about that. So if you have an RV volume overload, the things you want to typically think about, do you have tricuspid regurgitation? Is there any left to right shunts? Is there pulmonic regurgitation, or is there congenital heart disease? For pressure overload, you're thinking more things like, is this PE? Does he have pulmonary hypertension, pulmonic stenosis, pericardial disease, or it could even be caused by left side disease, or again, congenital heart disease. So this person had both. So going back to here, actually, this is the picture which is kind of pathognomonic for what was going on. And I know I asked what the sign was, and I'll give the answer in a second. But now knowing kind of a little more about the case and going back to the sign, what do we think the diagnosis is? He actually just had severe pulmonary hypertension, severe precapillary pulmonary hypertension. His pulmonary pressures were up, as you can see, in the 80s and 90s here. So that was the point of this case. I wanted to just go through some of the echo signs of pulmonary hypertension. And really you could tell a lot from the pulse wave at the RV inflow, or at the pulmonic valve, I should say. Not the RV inflow, the RV outflow, but really the pulse wave at the pulmonic valve. So some of the things you want to look for is acceleration time. So an acceleration time, which is the time from the start of the RV outflow to the peak of the PW through the pulmonic valve. You want it to be, if it's less than 105 milliseconds, that's considered too fast. So you'd have elevated pulmonary pressures. And you also get this sign, which is called mid-systolic notching, which is quite pathognomonic again, that you have elevated pulmonary artery pressure. So this is what it should normally look like. This is what it looks like in situations of high pulmonary artery pressures. If you have pulmonic regurgitation, there's actually a lot of hemodynamics that you could calculate based on this. One of the easiest ones that I find is that the velocity at the beginning of your PR jet, if you use Bernoulli's and do the velocity squared times 4, that will actually estimate your mean pulmonary artery pressure. Going back to the question before, B bump and L waves are slightly different, but they're also signs that you should know. So B bump you get on the M mode through the mitral valve. And what it is this notching right here between the E and C wave. And it's a sign that you have elevated left ventricular end diastolic pressures. And the L wave, also known as the bat sign, because it kind of looks like a bat with his 2 wings, is something that you see on the mitral valve inflow, the PW through the mitral valve. And it's a sign that you have elevated left atrial pressures or diastolic dysfunction. So there is only a couple minutes left. So I'll go through this case very quickly and then we can stop it there. So 55-year-old lady in the ICU who has a troponin rise, very typical case that we get. So again, LV function looks down. This lady's clearly very tachycardic. The LA seems to be enlarged. Skip that. Valves, there's some, at least, mild MR, trace to milds, but we'll go through this rather quickly. So here at the base, it seems like the function is okay. Maybe a little down. I hope these videos are loading up. I'm sure it might be a little choppy. At the level of the pap muscles, it seems to be worse, especially in the lateral wall area. And the apex to me seems a little better than what we saw at the pap muscles. I know the quality of these images isn't the best, and again, I'm sure it's choppy for everyone on their phones. But what I wanted to show here is that it seems like the apex is relatively spared. The anterior lateral wall may be down. There might be a little more contraction at the base, but certainly the mid seems to be the most affected, and the mid inferior septum seems to be the most affected. And again, here, the inferior septum seems to be down. Skip through this, and I was going through diastology, the resonance. So here more of the same, but just a little more clear. But the apex appears to be spared. The inferior septum looks akinetic. And to me, it seems like the base of the anterior lateral wall is contracting. You know, probably mild to moderate or moderate MR. And same here, it seems to me like the inferior wall is down. Looks like the anterior wall is contracting well though, and the apex is contracting well. And in the 3-chamber, I get the impression again that the septum is down, but what I find interesting here too is that the apex is spared, and it seems like the mid inferior lateral wall isn't contracting as well as the base again. We could skip that. So what they said, the impression was normal in size, LV between 30 to 35% with multiple regional wall motion abnormalities. The RV is normal in size and function, and they had moderate MR due to restrictive posterior leaflet motion with bilateral pleural infusions. So my question is, what is the most likely diagnosis here? Is it an LAD infarct? Is it a circumflex infarct? Did the diag go down? The RCA? Or is it Takotsubo's? So it seems like everyone's saying Takotsubo's.
Very informed group again.
Yeah, very exactly. So yeah, you guys got it. And that's exactly it. This is the point when I was going through with the resonance, what I wanted to make was when you have regional wall motion abnormalities and there's apical sparing, but the basal and mid segments appear to be effective in some ways with the apex spared, you really have to think Takotsubo's because that's not a true coronary, there's no coronary artery that would give you that distribution that spares the apex. So the only thing, this is how I'll end it, is just remember that there is multiple variants of Takotsubo's. Typically, we'll get the apical ballooning where the apex is down and the bases are hypercontracting, but you get all sorts of variants of it. You get a mid-wall variant, which is what they felt that this lady actually had, and typically that occurs with when you have some catastrophic neuro event. You could also get reverse Takotsubo's where the bases are down, but everything else is working. You get focalized or focal or localized. Usually that's the LV free wall. It can affect both, or you could have isolated RV sparing or isolated RV Takotsubo's. And again, I'm not going to go into this too much, but what they think is that there's two effects that cause this. It's direct cardiomyocyte damage from the catecholamine surge itself. And then they also think that there's some long-term down-regulation of the catecholaminergic beta-adrenergic receptors that leads to your LV systolic dysfunction. But I will leave it at that. It's 8:58. I never like going over time. So there's one more case, but we'll just end the presentation there and maybe leave it open for any questions, comments, concerns that anyone had, or if anyone wants me to go over anything from the cases, I'm more than happy to do that.
Once again, wants to thank Dr. Ryan Quinn, our medicine man, who did this really interesting case series of presentation, and also using Poll Everywhere to sort of demonstrate the remote engagement. So once again, thank you. Any question? So going one, going twice, I think it's coming up to 9 o'clock. So wish everyone a wonderful, happy, and sonographer week. And thanks for all the sonographers who work with us. Forever grateful.
Thank you so much, everyone, for listening and for your engagement. It's much appreciated.